Good evening, everybody. How's everyone doing? I'm going to give it a second or two to make sure everyone can pop on okay. Good evening. I'm Dr. Pete Stibbs, Senior Vice President of Global Medical Affairs and Medical Director at Argon Medical. Welcome to tonight's ACES virtual webinar, DVT Fundamentals and Achieving Outcomes with User-Controlled Aspiration. We're excited to bring you this focused session on practical strategies for managing deep vein thrombosis with a particular emphasis on user-controlled aspiration techniques and optimizing outcomes in real-world scenarios. I'm pleased to be joined tonight by two outstanding faculty members, Dr. Alexander Mazzono, Chief of Interventional Radiology at Hoag Hospital Irvine and Director of Marketing and Business Development at Newport Harbor Radiology Associates, and Dr. Capella Watermore, Director of Interventional Radiology Research and Interventional Pediatric Radiology at Montefiore Einstein. Both speakers bring deep clinical expertise and a forward-thinking approach to intervention, and I know their insights will be valuable for all of us. As a reminder, we'll have a Q&A session at the end of the webinar. Please feel free to submit your questions at any time in the Q&A section of your screen, and we'll address as many as time allows for this. And with that, it's my pleasure to kick things off introducing you to Dr. Alexander Mazzono. Dr. Mazzono is a Harvard-trained vascular and interventional radiologist and Chief of Interventional Radiology at Hoag Hospital Irvine with Newport Harbor Radiology Associates. He brings a unique blend of clinical, business, and academic expertise, holding an MD, MBA, and AV from Harvard, and having previously worked as a consultant with BCG. Dr. Mazzono completed his radiology training at Massachusetts General Hospital and fellowship at the esteemed Miami Cardiac and Vascular Institute, Miami, Florida. He's also an active educator, speaker, and researcher with over 50 scientific contributions across leading journals and conferences. It's my pleasure to introduce you to Alex Mazzono. Alex, take it away.
Thank you so much, Pete. That was a very gracious introduction. I have no idea who you're talking about, but I'm glad to be here. It's a true honor to be here with you all tonight. I am an interventional radiologist. I practiced in California near the ocean, and I hope all of you can visit me someday. And I have the tall order tonight of kicking things off and while trying to summarize everything I know about DVT and DVT intervention in a succinct fashion. And so I struggled with this, but I want to center everything around our patients. And before we begin today, a slice of humble pie for every single one of us on this call. So, you know, how long have we been doing mechanical thrombectomy? How long have we been doing aspiration thrombectomy for our patients in this new world of intervention? We've been doing it for years and years and years. In 2023, the National Blood Clot Alliance, which is a big patient advocacy organization, of course, that you're probably familiar with, did a survey of 1,000 patients with venous thromboembolism. I was shocked to see what came out of that survey. First off, patient satisfaction is poor. Over a third of patients said they didn't get the correct diagnosis the first time. Half of them required multiple physician visits before they actually got that correct diagnosis. And maybe not surprisingly, almost half of patients were dissatisfied with the first conversation that they had with their doctors about VTE. Shockingly, almost a third of patients bounced back to the hospital because their symptoms didn't improve. What does this say to me? It says to me we're failing, but it's also the answer as to why we're here today. We are here to solve this together. We are here to solve the problem of VTE. And specifically tonight, we're going to talk about DVT. So I'd like to have a little bit of a homework assignment for everybody on this call. If you haven't done this already, please do this sometime if this is something you care about. Go on your favorite social media outlet that has patient forums, Facebook, Reddit. This is a patient from Reddit. These are recent posts. This patient had a DVT at age 26. They are now 28 and they're still suffering. Not only that, their doctors are telling them there's nothing they can do. That's crazy to me. I wish that patient would get sent to my clinic. Here's another patient who actually got a DVT. They couldn't afford blood thinners. And now they're posting from the ICU with what sounds like a pretty severe pulmonary embolism. And yet another patient, DVT 10 years ago, and now has a recurrent DVT this past year. They are puzzled why the treatments and the attitudes are so different between 10 years ago and now. And while we know that could be driven by modern care, it sure sounds like nobody explained it to them. So I would ask you to think about what your experiences have been, but also do this little homework assignment. But suffice it to say, I believe we've got a long way to go. We're spending the next 55 minutes or so talking about one way to go about it. I think we're going to explore, we're going to learn, and we're going to drive patient care forward, starting today and continuing on this journey together. So now that I've said that, let's get boring for a moment. Let's talk about epidemiology. No VTE talk ever is complete without the infamous triad for hypocoagulability. You'll probably find that nearly all of your patients have at least one perturbation somewhere on this triad, something listed here in red. But why does it actually matter? Right? You memorize this as a student, you're taking your boards. Why does it matter? It matters because it's real. It's because for every one patient you've seen who has a DVT, there's actually countless more who are at risk. Most of you probably know a friend or a colleague or family member who had a DVT or a PE. I certainly do. This is real. There was an estimate from the literature 20 years ago that at any given moment in time, there's probably 12 million patients at least at risk of developing VTE. And I bet you if we did this analysis today, that number would be much, much higher than that. Now, it's actually difficult, surprisingly difficult to quantify DVT diagnosis. I mean, when I was a consultant, a management consultant, we used to be tasked with things like this, trying to figure out what these numbers are. Do you do bottom up? Do you do top down analyses? I'll tell you what, the data are noisy, but probably in the United States, we have somewhere in the order of 300 to 400,000 patients a year that are being diagnosed with DVT. But many epidemiologists, when I dug into the literature, I learned that they believe there's probably another several 100,000 patients that have either underdiagnosed or missed DVT diagnoses, so-called silent clots. No matter how you slice this, that's a lot of patients. And the one thing that's not on this slide, because it's hard to quantify even more, industry stats reveal that only a fraction of these patients are actually treated with true modern techniques. So in coming years, this will only go up. Elements of Virchow's triad will continue to grow. These are things, whether it's aging, cancer, surviving cancer, medications, obesity, other comorbid conditions that are continuing to just increase and increase and increase. Of course, this is all enabled by something good, as organizations like the National Blood Clot Alliance, physicians and care providers like yourself increase disease awareness. Of course, that's also driving DVT incidence. As such, we are facing a deluge of patients ahead of us. Most likely, with the epidemiology, the way it's going, the factors driving patient population and identification, we're just going to see probably at least a doubling of patients over the next 30 years. As an aside, I'll comment, that means that your job is going to get harder. You're going to have to get better at treating these patients. We all are. We're going to have to get more efficient at diagnosing, working up, and intervening on these patients and getting them through the journey of DVT and also PE, by the way, in an efficient and effective fashion. Despite this increase in incidence and prevalence that we have already been seeing and we will continue to see, this does remain a bit of a silent epidemic. This I found fascinating. Research on public awareness of these conditions. Patients don't know much about DVT and PE, at least not until they're diagnosed with it. And they're also not, well, surprisingly not, or not surprisingly, poorly educated about the risk factors of DVT and PE. There's much more popular, I suppose, conditions out there that patients, all of them know. DVT and PE are not amongst those. And perhaps due to our difficulty in treating our patients efficiently and effectively, this is expensive. And we're talking many, many, many billions of dollars of healthcare expenditures that are directly attributed to these conditions, and probably much more than that as kind of add-on costs of taking care of patients that are going on Reddit and posting, and nobody seems to be able to help them. Beyond the statistics, I'm going to circle back to where we started. It's patients and it's their stories. And we have patients who are suffering. We have patients in debilitating pain. We have patients who cannot do their activities of daily living. We have patients who are living in fear and in frustration. We have patients who have limb threat and, of course, acute and perhaps fatal pulmonary embolism. But there is hope. And again, that's why we are all here together tonight. All we have to do, and I suppose it is a very big task, all we have to do is work together to ensure that all of these statements come true. We are going to treat almost any patient with venous thromboembolism effectively. We are going to compete, we are going to innovate when it comes to the industry side to bring new concepts and new techniques and new devices to market. And we are, of course, going to work on the clinical side, increasing disease awareness amongst doctors and patients, improving diagnosis, improving access to care. No matter what country you're in, these are actually struggles. And so we must work together to ensure that each of these does come true. So what is it about DVT? Like, what's the deal? What's the deal with DVT? Well, I'll tell you what, let's talk disease. It's actually really hard to talk about DVT. It's hard to organize thinking about DVT. By the way, how do I know that? Because I was tasked with putting this presentation together and I realized, hey, this is kind of hard. It's easy to go and kind of do my day-to-day and treat a patient with DVT, but it's hard to actually talk about it systematically. And why is that? And I settled on this. This is my answer as to why that might be challenging. It's because it's heterogeneous. Heterogeneity in medicine is typically not something we want, right? It does make things interesting and intellectually stimulating. You know, if you want to be on rounds for an hour talking about something interesting, heterogeneity is great. But in reality, it makes our jobs more confusing and stressful. And so why is that in DVT? Well, it's 4 big categories I'm presenting here. There's probably more. But presentation, you know, patients come in with a variety of different complaints. Some of them, it's just leg swelling. Some of them, it's something else like back pain. Sometimes it's both. They come into varying sites of service. Maybe it's the specialist office. Maybe it's the urgent care. Maybe it's the ER. Who knows? Their clot is heterogeneous. If you've ever done a single thrombectomy case, you will teach me that you notice that clot morphology is heterogeneous. The physicians, the care providers are heterogeneous. There's a dozen different types of doctors who may initially see a patient with a complaint that may relate to DVT. And usually it's not any of us on this call. Usually it's not IR, IC, VS. Those of us on this call, it's usually other doctors altogether. And interventions are also heterogeneous. There's so many different ways to attack this. And truth be told, across the country, across the world, modern technology is just still beginning to take hold, believe it or not. So on one hand, again, this is super interesting and stimulating. It can be confusing and stressful, but I would encourage you all to look at this heterogeneity as a puzzle and a challenge. And we are going to fight this disease, and we are going to defeat DVT, and it's going to be incredibly, incredibly rewarding. The other thing about, by the way, kind of the pathophysiology in the world of veins and DVT. Well, we spend a lot of our time in the arteries as interventionalists. The arteries are high pressure. We know them. We're fairly good at working in them. But the veins are really low pressure, and with low pressure comes low velocities. And what does low flow mean? Low flow has a lot of unique disadvantages. And no, I'm not a hater. There are a lot of great things about veins. They are supremely malleable, capacitance vessels. Some would say perfectly designed to carry blood back to the heart. But while the artery's kryptonite might be atherosclerosis, the low flow, low pressure state of veins may very well be their kryptonite. Lack of shear stress, prone to stasis, lack of pulsatility, valve pockets, all in the context of deoxygenated blood, which itself is more prothrombotic. So I don't know if any of you have been whitewater rafting. I have, and when I went, it kind of looked like this. So it wasn't nearly as fun as I thought it was going to be. I was looking forward to get kicked out of the raft, but we were on board the entire time. But let's use it as a thought exercise. So this is a low flow, low pressure system. Maybe you do get a little bit of clot there, and that's my little drawing of some clot, but the river is still flowing, And then maybe you get a little bit more clot on top of that. The river is still flowing. Maybe it's been days now. And then finally, that vein may occlude, but at that point, it may have been weeks. The nature of DVT composition, which is one of those points of heterogeneity, I would call DVT the great blood clot shapeshifter. And we've been characterizing these models for decades and decades and decades on histopathologic examination, anatomic examinations, postmortem examination. We know this to be true. In stage 1, venous clot, it's basically a loose fibrin network that can be honestly easily treated, probably medically. But within days, it's already starting to become organized and inflamed, which is not a great combination. And then a week or so later, it's basically turning into scar tissue. And for those of us pathology nerds, I used to be a pathology nerd myself. Here's an actual MSB stain, which stains for fibrin. And what I have learned is fibrin is mostly yellow or red on these MSB stains. And you can see here and track this as it goes. First couple of days, there's a lot of yellow and red in there. But after about a week, 2 weeks, 3 weeks, not only has the amount of stainable fibrin decreased quite a bit, but the venous architecture has actually been partially destroyed. So it is this rapid evolution of DVT that confuses even the greatest minds in medicine, and why we struggle to treat. And when we fail, right, when we are unable to treat in time or unable to treat at all, our patients succumb to post-thrombotic syndrome. This is where the veins and the valves, they fail. The legs become heavy. The skin becomes discolored. Those changes may be inevitable. And the patients can even get ulcers. And this debilitating condition, by the way, in its most severe varieties, has quality of life scores that are equivalent to that of end-stage COPD and end-stage CHF. So don't let anybody tell you that this is not a serious disease. And is this rare? No, it is not. It affects up to 50% of our patients. So we must work to eradicate this disease. And again, I now return to history. We have come a long way. We've tried medical management. We've tried surgery. We've tried various catheter-based techniques. And now we live in an exciting era of catheter-based percutaneous endovascular thrombectomy. And we are transforming the paradigm of care for deep vein thrombosis. And that leads me to my last bit. I'm on my soapbox. I'm really enjoying it. Thank you for the honor of being here with you all to talk about this, something I'm very passionate about. And I'm going to close my section with these comments. If there's one thing we all take away from today, I want to change our nomenclature once and for all. What are we doing with our thrombectomy technologies? No, other places in the body too. Let's think about that. What are we doing? We're revascularizing. Revascularization is no longer just for the LAD, for you cardiologists out there. It is no longer just for the middle cerebral artery, for you neurointerventionalists out there, or the SFA, for all of us. Revascularizing is also for the veins. So let's stop saying we're going to, quote, treat this DVT or treat this patient with DVT. Let's say we are going to revascularize, but not so fast, right? We have code neuro for ischemic stroke. We have code STEMI for ST elevation MI. What do we have for symptomatic DVT? Well, we don't have a code DVT. Maybe some of you do. I don't have one in my hospital. Maybe one day. But here is my excuse. We don't have a code DVT because the disease is in fact so heterogeneous. But I am committed to revascularization and I'm committed to change. And this is where algorithms come in. Does your algorithm look like this? I don't know. Does it have to? No. Can you copy this one? Absolutely. I'd be thrilled if you did copy it and you can have it. But algorithms are critically important to ensuring that care is delivered in a reproducible fashion, in a reliable fashion at your facility. It's also helpful to have tips and tricks to adjust common questions before they even get asked, by your ER physician or your medicine doctors or hospitalists, right, to help guide workup. So they're already doing that workup for you before they even call you. By the way, for the one person here who actually wants these algorithms, here's the QR code to download them. Take your picture, and one more second, and I'm going to move on here. Hopefully someone's downloading this. But let's change gears, right? So now what happens? You went through your algorithm, you got your call, you got your consult. The disease may be heterogeneous, but that's where the excuses should end. You should be systematic. For every case that admonish you to look systematically at every single one of these factors, it's going to make you a better doctor, not just today for that one patient, but for every patient going forward. What's the Volotha? How old do you think that clot is? Can the patient take anticoagulation? Can the patient go, or has the patient undergone a complete workup? And will this patient benefit from intervention? And my colleague is going to dig into and show you some actual technical cases with the Argon cleaner system, which we're certainly excited to talk to you about today. But think systematically about things like where are you going to access? You have a lot of optionality with this, no pun intended, for those of you who use the option filter. Jugular vein, common femoral vein, popliteal vein, where are you going to go? How are you going to get there? Where's the patient positioning? Where are the access points? How are you going to do the procedure? Think systematically. And before I close, a moment of silence for every occluded vein that was unable to be crossed. You know the feeling, you've solved the great mysteries and heterogeneity of DVT, and you're ready to intervene, but you can't cross. It's really frustrating. Have a system. Use my system. Whatever your system. Have an escalation plan for crossing, which is one of the most frustrating parts of this heterogeneous disease. And I don't plan to sit here and go through every point of this summary here, but be detailed, be systematic. Let us help you, right? There's an incredible amount of experiential wisdom that is housed in Argon's network that you can get access to. The tools are the tools. The overall clinical picture, the overall clinical drive, and the way you manage these patients, that's where you differentiate yourself. So please help us get you through it all. And the tools. What have we got? I said the tools are the tools. Argon's CleanerVac system is, in fact, unique. My colleague will show this to you, but I do want to call out some optionality and flexibility of the system using some very rudimentary drawings just to show you what can you do with this kind of system. Let's say you've got an iliofemoral DVT. By purple there is the clot. You can come from below and treat it. Let's say you got the same patient, you can come from above and treat it. Let's say you've got an iliac DVT, you can come from below and treat it. Or you can come from above and treat it. What about a patient that you got to treat this iliofem DVT, but they can't go on their belly? You wanted to go prone and access popliteal, but you can't. Well, you can go up and over. And what about a complex iliocaval DVT where everything's thrombosed and one of the profundas is out? Well, you can come from above and treat everything, including the profunda. So sticking with the Argon tradition, and I am about to hand it over, sticking with the Argon tradition, you can dream up many ways to treat your patient, no matter how heterogeneous that situation may be. And I hope that, well, I hope that we recognize DVT can be frustrating, but it's incredibly powerful and rewarding when we defeat it. Let's be systematic and learn from each other as we tackle patient management and intervention. And I'll circle back one more time to the patients. They are suffering, and mastery of these interventions can change their lives. So with that, I will close. Thank you so much for having me here today. Thank you, Pete, for that gracious introduction. And I look forward to your questions, and I will sign off. Thank you.
Alex, truly a pleasure. Thank you so much. Your advocacy and passion for this topic and the subject, it's really inspiring. And so one thing about you that I've always appreciated is that you live this disease state. It's your passion. It shows in how you talk about it. It shows in how you relay the information on it. And man, I could just listen to you talk about it all day long because I think it resonates so deeply. And so speaking of resonating deeply and someone who's passionate about VTE, it's my sincere pleasure and honor to introduce Dr. Kapil Wadamur. Dr. Wadamur is a director of interventional radiology research and director of pediatric interventional radiology at Montefiore Einstein, as well as assistant professor of radiology at Albert Einstein College of Medicine. He completed his MD at Rutgers University, his internship at Yale, and an integrated IRDR residency at Montefiore, where he served as chief resident. With a background in biomedical engineering from Columbia, Dr. Wadamur focuses on advancing interventional techniques, medical devices, and outcomes research. He's a frequent presenter and published author. He's also a member of Argon's Innovation Advisory Board, reflecting his ongoing collaboration and passion for biotechnology innovation. I'm now going to turn this over to Dr. Wadamur. Kapil, thank you.
Pete, thank you so much for the very generous introduction. And Alex, you really did a phenomenal job of laying the groundwork here for DVT. I definitely learned a lot of things from your talk. So I was tasked with presenting some images to go with some of these concepts. So my name's Kapil Wadamur. I'm at Montefiore Einstein, coming to you from the other coast. And we'll just get right into it. I'm going to show you two cases. The first one being a DVT case, and the second one slightly switching gears. It's going to be a portal vein case, but really wanted to highlight some of the tools here in the armamentarium that Argon has. So we'll jump right into it. So the first patient is an 86-year-old female. She was ambulatory, had a couple of chronic comorbidities, and presented to the emergency room with left lower extremity swelling and redness that was going on for 3 days. So she underwent a duplex of the veins, and it showed a left-sided DVT. Some of the findings were that she had an acute occlusive DVT in the common femoral vein, also involving the SFJ, the femoral vein, and popliteal vein. And she was noted to have partially occlusive thrombus below the knee as well. And so our service was consulted. We started her on a heparin drip and ordered a CT venogram to evaluate the extent of her clot burden. And so here you see some axial images showing you the extent of the clot. A couple of findings that I'll just point out for you is that there's clot extending into the cava, into the infrarenal IVC. The profunda is also thrombosed, which you see here. And we know from the ultrasound that she has some calf veins that were also thrombosed. And so, we had a number of reasons here to be worried about inflow. Inflow from the calf, inflow from the thigh into the cava. And looking at the big picture in discussing the management options, we ultimately decided to perform thrombectomy given the fact that she was ambulatory at baseline, but now she wasn't. She did present with acute pain and swelling. And if there's something that we learned from the ATTRACT trial and from some of the other research in this area, is that we do have a chance to reduce the chance of, or at least the severity of post-thrombotic syndrome in patients with iliofemoral clot burden. And so we gave consideration when we started this case to a number of different access sites. Ultimately, we decided that the right IJ would be the primary access site, and that was for a couple of different reasons. Firstly, favorable vectors for thrombectomy. That access would also allow us to place a filter. It would give us access to the entire extremity from one access. You saw the illustrations in Dr. Misono's presentations. There's so many permutations and combinations to come at this, but this is one access that allows you to treat the entire extremity from one point. It also does not compromise inflow at the access site, such as a popliteal access might in certain situations. And of course, it comes with some limitations, such as working through a filter that you just placed, as well as length of catheters is something that has to be considered when working from the neck and going down to the extremity. We also used the right common femoral vein as an adjunct access. This was very important. It proved critical in a case like this and very helpful for intermittent venograms. Just having your working access separate from this access that was dedicated to runs made things a lot more efficient, and I highly recommend that in similar kinds of cases. The adjunct access also allowed us an alternative access for up and over intervention if we needed to resort to that. We gave consideration to the left groin as well as popliteal access and posterior tibial vein access, but ultimately did not have to resort to those. And so the first order of business in this case was placement of an IVC filter. So we placed an infrarenal optional lead filter. This served not only as embolic protection during the procedure, but also during the peri-procedural period while AC was still being established. I mentioned the patient had a couple of comorbidities. One of them was hemorrhoidal bleeding, and it was unclear how severe her intermittent or prior bleeds were. And so this was another reason to have a filter. A lot of times, we don't know how a patient might tolerate AC. And so having that filter in peri-procedurally can help, especially when you might bring the patient back for a follow-up venogram or for a completion procedure if necessary. And so this is an image now. We got to work through the filter. We placed first an 18 French 33 centimeter gore dry seal sheath coming from the neck. You see that sheath was just long enough to make it past the struts of the horizontal bars on the option elite, and so that allowed us to work through it securely. Of course, this was an area that we frequently kept our eyes on during the procedure. We were very cognizant of the fact that we're working through a freshly placed filter, but through that, we advanced the 18 French 115 centimeter long VAC aspiration catheter. So that was the workhorse of the case, and we brought that catheter to the face of the clot. A couple of points in my experience using it is that it has a nice flexible dilator. The dilator has just the right amount of rigidity to be able to guide that sheath down. It also tracks pretty well. And the other thing that was worth noting about the whole device and setup is that it comes with a handheld component so that you can modulate your thrombectomy in real time. And you actually have control at your fingertips, quite literally. And so bringing down the VAC aspiration catheter to the face of the clot and performing thrombectomy, we noticed that the flow had immediately stopped, suggesting the clot had lollipopped, as we call it. And at that point, we held suction for 20 seconds, just in case something might move and give, but it didn't. And for that reason, we pulled it out of the dry seal on suction and flushed it on the back table, which revealed organized clot. And so this was the image on the left that you see is an injection through that through the sheath, showing that there was no additional thrombus hiding in there after the lollipop event. And you're seeing on the right image, this is an injection through that adjunct access that I mentioned in the right groin. Again, very useful, especially considering the direction of blood flow, in this venous system. That helped a lot. And you see that the clot is debulked. There's still some there. We went at that caval component of the clot a few more times with another 1 or 2 passes with the vac catheter, and then directed attention to the remainder of the extremity. And so the technique, I'm going to illustrate to you the technique that we used to pretty much clean up the extremity. And the goal here was to advance the catheter down to the popliteal vein and perform stepwise thrombectomy, pulling back and kind of treating one segment at a time. And during this process, I noticed the vac catheter tracked very well over a long distance and also through tough clot. These cases, kind of in line with the heterogeneity that Dr. Misono was talking about, clot ends up being more chronic than we think it is, based on what you read in the chart or when you first see the patient, based on the history that they provide. Clot's been evolving over a longer period of time than we think. And so this clot, it felt tough, but the catheter tracked pretty well through it. And during that process of making it down the leg, the catheter also kind of doddered through the clot, pushing it away and making a central channel for blood flow. I feel that in a lot of these thrombectomy cases, flow is really everything. And even if your endpoint is not removing 100% of clot, I think it's paramount that you leave with good flow that can then take care of whatever residual clot is there and allow the body to resolve it. So here's the catheter now. It's made its way down the thigh, and you see that it's not quite in the expected location of the femoral vein. That's because on its way down, it entered the profunda. Again, one of the limitations working from the IJ coming down the leg is in a thrombosed system is you don't really know where you're going. It's not like an artery where you can do a roadmap and you can see where you are. There's no real-time guidance for this, and so it's a mix of knowing your cross-sectional imaging beforehand, but also having ultrasound at your disposal and just paying very close attention to the position of the catheter. And so while we were in the profunda, we did treat it because it was thrombosed, and leaving this patient with inflow at the end of the procedure was also one of the goals, to allow continued patency. And so we treated the profunda, and I'm going to show you now the technique that we used to treat the profunda, but also the rest of the extremity. And this was the retrograde technique that we used. So bringing the catheter all the way down, the catheter has the actual cleaner device through the catheter. The cleaner device has a side port. It's very useful. It can be used for contrast or TPA. And so instilling a small amount of TPA through the cleaner, and then macerating a segment of vein at a time. So the aspiration catheter was parked during this, and the cleaner was used to macerate kind of up and down in a dedicated segment, and then aspirating that segment with the vac catheter, performing a venogram through the cleaner post aspiration, looking for that patency, and then pulling back the entire system to the next segment of vein above that, and cleaning that in a similar fashion. And so pulling back and repeating back to the iliocaval confluence was pretty much how we addressed the whatever clot was remaining here. And you see on the right sided image, this is post aspiration, venogram through the cleaner. There's great patency, there isn't great flow yet, which is going to be a function of cleaning up clot that's higher up. So I have a few representative images here from different stages of the procedure. I wanted to illustrate a couple of features that make the cleaner vac system unique. The image on the left, you see that this system works in 2 places at the same time, right? It's working not only where the catheter is aspirating, but also where the cleaner device is macerating. That's one thing that makes this unique. The other that you see in the middle picture is the way that the cleaner device and the aspiration kind of interact with contrast. makes it's very useful, and it gives the user a lot of feedback. So contrast kind of bathing in clot, you can actually see that whole column macerate in real time. And when you aspirate, it disappears right before your eyes. So you have some kind of feedback to know how much clot is remaining and if it is being macerated, and you can control your aspiration based on what you see there to minimize blood loss. And the last picture, you see the cleaner device in the iliac vein, probably in the common iliac. And you see that the device, it opposes wall to wall. So unlike your balloons that you might have to size to a certain vessel, this device self-sizes, and it's nice that it's a single device that you can use to treat any part of the extremity in these cases. And so we didn't have to do any exchanges, and it allows it to treat mural thrombus effectively. So at this point, we've treated the profunda, the femoral vein, all the way up to the common iliac, and veins are widely patent now. However, the flow is still slow, and that's because of some chronic thrombus that's remaining at the iliocaval confluence. And so the remainder of the case was directed to that area. You see the cleaner behaving a little erratically there. That's because of that chronic thrombus. And the caval clot is gone by this point. So really our focus now was how do we eliminate that chronic thrombus and prevent this patient from rethrombosing and just get to that point where we can leave her at least on anticoagulation and hope that she maintains patency. So a couple of more passes with the aspiration did not really give us that much more clot out. Again, this was very wall adherent, stubborn kind of thrombus. We used other tools that we had at our disposal as well, including a couple of Fogarty sweeps. Here you see that we used up and over access. Again, a lot easier than coming from the neck and being limited with catheter length and just being able to see everything on the screen, not having to interact with the filter unnecessarily. That's one reason for the adjunct access here. And then we angioplasty that area to 12 millimeters. And after doing that, the flow was improved. There was still a small amount of stubborn non-occlusive mural thrombus, but the flow was excellent at this point. We considered stent placement, but the flow was significantly improved. And now with inflow from the GSV and profunda and having anticoagulation on board, which she did not before, those factors, we looked at them and we elected to follow her up, keeping her on anticoagulation. So we sent her back on heparin drip and compression devices for her calves. And the following day, she was transitioned to a DOAC. In this case, we used a total of 8 milligrams of TPA, and the estimated blood loss was less than 300 cc's, about half of which, though, was in that final aspiration at the confluence on that chronic bit. So we brought her back in 12 days after she was tolerating a DOAC well. She had significant improvement in her left leg swelling, and at this point, venograms showed wide patency with excellent flow. So that bit of chronic clot at the left iliocaval confluence had gone by this point. It disappeared. It resolved. The filter, for that reason, we were able to take out the filter. She was tolerating AC without an issue, and so we used the Atrieve snare kit to remove it, uncomplicated removal. And this was the final venogram post-thrombectomy. And she had excellent flow at this point. Her symptoms had significantly improved. I'm going to show you a picture of her legs before and after. And she was discharged on apixaban with follow-up with both our service and IR as well as hematology. And so that kind of shows you the dramatic difference that aspiration paired with maceration can make. In selecting patients with iliofemoral clot, I hope that all of you will be able to have similar luck with this exciting kind of technology and be able to help our patients restore flow and as Dr. Masono said, revascularize really, right, is getting that's our goal here in these cases. I'm going to show you a similar concept now, but this time apply it to a portal vein. And I'll take questions at the end. But this time, we're applying the same concepts, large bore thrombectomy. How do we leverage mechanical as well as aspiration capabilities of our devices to be able to clear out clot here and do so effectively? So this is a 56-year-old male. He has a history of chronic hepatitis B cirrhosis. Was decompensated. His MELD was 23. He presented with large volume ascites. He had a history of an episode of SBP, as well as intermittent hepatic encephalopathy, probably related to underlying shunts, esophageal varices. In fact, he did have an episode of bleeding from esophageal varices, which were ligated at one point. So he came to our service. We placed the tips in him, an 8 mm Viator, and we saw a nice gradient reduction from 12 millimeters of mercury down to 4. And so this is an image from the tips placement. You see that there's a coronary vein supplying some esophageal varices, and post-tips placement, the flow looks great. It's going through the tips, and we don't really see the varices anymore. The ascites improved post-tips. 5 months later, we dilated the tip stent to 10 millimeters because he was tolerating it well without encephalopathy, and his ascites further improved. Now, 2 months after that, so this is now 7 months post the initial presentation, he happened to develop, this was wintertime in New York. I don't know if the viruses going around are similar to what you see out there on the West Coast or in other parts of the country, but it gets pretty bad here. And unfortunately, he developed an RSV infection with increased abdominal distension that he noticed after that. And so he came back to us. This was his scan now. At this point, we see that the tip stent, as well as the portal vein, the main portal vein, is thrombosed, and that thrombosis continues throughout the entire stent back to the hepatic vein end of the tips. There's also a large amount of abdominal pelvic ascites that he reaccumulated at this point. And so we took him for a tips revision and thrombectomy. And even compared to the CT, the time it took for him to come to us, which was just a couple of days after that, the clot had already propagated more. And you see this is an SMV run, really a run at the portal confluence. You don't see any portal vein at all. Nothing is going through the tips. And so we used a similar technique here. We thought this would be a great case for the cleaner vac system. It's a large bore device, powerful aspiration, mechanical thrombectomy if needed, gives us the option to use lytics if we desired. And the vectors make a lot of sense here. We're coming from the neck. It's a pretty up and down trajectory. And the 18 French device, which imputes a 6 millimeter diameter, fits very comfortably through a tip stent, which at this point we had dilated to 10 millimeters. And so similar technique. In this case, we had actually laced the clot with a small amount of TPA to begin with, and then introduced the cleaner vac system. Again, it pushed through the clot, created a nice channel, and we introduced the cleaner to macerate one segment at a time, followed by aspiration of the macerated clot in that segment. The cleaner side hole was then useful for a venogram to show patency of that segment, and then we pulled back and repeated one segment until we reached the top of the tip stent. One thing to highlight here, similar to the previous case or any case with this kind of system, is your aspiration is going to be limited because your blood loss from aspiration is going to be limited because you are aspirating clot that's already been macerated. And that's kind of the beauty of the dual mechanism of action of this device. And so you see here the cleaner at work. It behaved very well even within the tip stent and in the portal vein. Again, it sizes to the vessel it's in. And you see it post maceration and aspiration of that segment. You have patency, but of course, there's additional work to be done in order to unlock the real flow of the portal system. And we did that working our way all the way back until we had good patency and flow throughout the tips. And so the result of this case was evacuation of a large amount of clot, which we thought was subacute. The patient was discharged on apixaban. We treated with 5 milligrams, and after that point saw continued improvement in the ascites. So the patient had a 3-month follow-up CT, which showed continued patency of the tips and resolution of the ascites. And what I wanted to highlight here was if you look at the area around the tip stent, even up here in the portal vein, I'm not sure if you can see my cursor, that area was previously thrombosed. Here's a before and after. So even though the cleaner did not come in direct contact with that area, this is a testament to either the power of the aspiration or at least the ability of the cleaner vac system to facilitate creating a channel, making good blood flow and allowing the body to resolve whatever residual clot might still be there. And so resolution of ascites and patent tips, we were happy with the outcome in this case. And so the principles are the same in any kind of large caliber vessel thrombectomy. You're looking for flow, you're looking for resolution of clot burden, and I kind of outlined some features of the CleanerVac system that I thought were very helpful here and very unique to the system. And so to recap them, the dual mechanism of action, both maceration and aspiration, allows you to expeditiously treat a segment of vein in one pass. Clot that's already been macerated, it aspirates pretty easily, and that allows you to minimize your blood loss as opposed to coming at it with aspiration alone. The aspiration itself is powerful. It allows you to aspirate chunks of even more organized thrombus, as we saw in the first case. And the 18 French device is well sized to allow you to treat large vessels, including IVC and portal vein. You can choose the way that you aspirate. You can pulse. You can do continuous aspiration if you think you're lollipopped on something. Those are all very useful features of the device. The wall-to-wall apposition of the cleaner device itself sizes. The lumen, the little side port on the cleaner device, also very versatile, allows you to inject contrast or lytic. You can do the case lytic free if you like, and you can use contrast to take a look and see it interact. You see real-time visualization of the maceration and the aspiration when you have contrast on board. And lastly, the device is ergonomic. It's intuitive. It gives the operator complete control over the technique. There's a sterile vacuum chamber that's placed on the back table. It's actually on your field, and that's kind of nice. The chamber actually, there's a filter inside it that separates the clot away from the aspirated blood for easy viewing, and you can judge how much progress you've made without having to take the whole thing apart. And so with that, I'll end here.
Bill, thank you so much. What a pleasure. And thank you for sharing your experiences. Alex, I'm going to have you pop on if you can. I have a couple of questions just because I'm curious and I can't let you guys go without picking your brains. One of the things that we all agree about is specifically how do we get these patients in an earlier format and bring them into the care clinic and into the care spectrum earlier? One of the most frustrating things, and I kind of debate on discussing chronicity because I think that's controversial. When we talk about wanting to get these patients in an early stage of acuity, I think we found a lot of things, especially looking at the recuts of the CLOUT trial and the histology of thrombus, that even trying to base an evaluation on patient clinical presentation is probably a false prophet and a fallacy because there's so many other factors: pro-inflammatory state, a patient's immunoresponse, whether they are oncologically compromised. There's many different things I think affect collagenization and cross collagenization of thrombus. So the soonest that you can get a patient in, the earliest, is going to be the best outcomes possible. How do we do that with so many different stakeholders? And I'm gonna start this actually with Alex, and then I'm gonna ask Kapil the same question. How are you managing it in your hospital setting? And what's unique is you have Alex, who's in a private practice setting, and then you have Kapil, who's coming from a major academic center in New York. And I'd like to see if there's variability or how you're managing that individually.
So, of course, Pete asks like an impossible question to answer, and it's something that we're all fighting. I think everybody on the call, everybody who's joining, is at varying stages of that fight. And I honestly don't think we're close to being done. My canned answer to your question is one based on the things that we talked about already, like algorithms, and my suggestion as a starting point for most practices is to create algorithms of care, organization around how patients will be identified and kind of put through the process of having a DVT at your facility, and have that done and have that created in a multidisciplinary fashion. So you're not just making algorithms saying, hey, here's my algorithm, follow it. You're actually creating these in concert with the other specialists who may be involved. For example, perhaps that's your ER physician. Maybe that's your ER PAs and NPs. And then perhaps it's your medicine docs or your hospitalists who are picking those patients up and then consulting you. But I must say that that is a very narrow-minded way to look at it. It is a pretty good place to start. You are going to find a good number of patients in an acute care setting if you're hospital-based in that fashion. But Pete, your question makes me think, what are we missing beyond that? And I think there's a much bigger world beyond that we have to figure out together. The patients who are out there seeing their primary care physician with leg swelling, you want to get called when that patient gets an ultrasound 2 days later and a DVT is found. Are we getting those calls right now? Probably not, right? Most of us struggle to get that call. So that's the next phase that we have to go to. And I could speak for about another hour about this topic, and so I'm going to pause there, but pose that as the next great frontier for us is not only do we have to solve inpatient medicine, which actually hasn't been solved, but we have to solve the rest of those several 100,000 patients with so-called silent DVT that are never getting to us.
Great answer. And it's always interesting. I ask these questions, and when I'm talking to an interventionalist, it's preaching to the choir. But I think it's important we get that information out there as a group think and start looking at that bigger agenda, the iceberg underneath the water that's going to crush the ship, not what we see in front of us. And so, Kapil, I'm going to turn that to you because I think you have a different, unique perspective in that you come from an academic center where you're dealing with all these different cross specialties that are interacting at the hospital level. How are you getting these patients into your system? And what's been your advocacy route, or is it already built into the system with regards to who sees and manages these patients at the forefront of the intervention?
Yeah, I agree with Alex's comments about algorithms. I mean, I think finding these patients and really getting them the care they need as soon as possible comes with thinking about the patient pathway. And so where are the patients presenting? A lot of patients, they come to the ED with new leg swelling. And so what happens in the ED? Who is the ED calling? How is the ED obtaining their imaging? When the imaging is performed, are we waiting for the read for then a clinician to then react to that? Is our response completely reactionary, or is there some kind of monitoring? Is there some kind of system in place for the ultrasound tech who's doing the scan to have a finding and know how to respond to that finding in real time, as opposed to a couple of days later the patient gets a message on the MyChart or the primary care doctor finds out and it's actually more clot than we think there is. And so I think being proactive, finding out where the imaging is being performed and how we're responding to the results is a really big part of it. In our institution, a lot of the duplexes are performed by the vascular lab, which falls under the purview of vascular surgery. And so that's, that might be different in other institutions, but it's something that anyone in an academic institution should know, where are the patients physically being imaged. The other thing is working in an academic center. A lot of referrers, a lot of your work is going to be a function of how do your referrers look at this disease process, right? So, for example, referrals that we get from medicine, let's say inpatients, they might be in the form of an order or a consult for IVC filter placement, not for a thrombectomy. This patient has a DVT. In some people's pathway or training, they might think that the solution for that is anticoagulation. If that's not possible, IVC filter, and it might be as simple as that. There's actually a lot of nuance that we all here know in the endovascular space. But a patient, in order for an IVC filter, the appropriate way to respond to that might be to educate the primary team in that case and see what more we can do for the patient. Can we actually clear the clot burden as opposed to just forgetting about it if they're not an anticoagulation candidate?
I think that is a great answer to that. And another kind of controversial question, there's a lot of competing service lines. And when we talk about crossovers between venous disease and arterial disease, whether it's interventional cardiology, vascular surgery, interventional radiology, in a setting where, especially academics, we see this a lot in private practice. How do you get on the same page when you don't have one singular owner? I mean, that's always a question that I scratch my head with because we know the unified stakes, the best care for the patient is a unified care. So whether it's vascular surgery that is doing the procedures or interventional cardiology, how do we get on that same page, guys? Especially, and I ask this because I have two interventional radiologists here, but we have interventional cardiologists that I personally work with, vascular surgeons. It's a very diversified field that are performing the interventions. How do we all get on the same page when we don't have unified guidelines to begin with? Alex, what's your thoughts?
Well, I think this is one of those things where there's so much opportunity and so much untapped. You want to talk about silent DVT, silent diagnoses, untapped markets, that this is a place where we can actually come together. You know, we're in most places I've seen, people aren't really fighting over this. They're trying to get people to help, right? We're looking for help. This is a disease state we expect to blow up. We expect the incidence to be going up, not down. And if you just look at what's driving it, it's quite obvious why that would be. For example, cancer used to be a killer in many cases, has now turned into a chronic disease. It's one of the main drivers of venous thromboembolism. So we need help. We need to work together, not to compete. And so to reach across the aisle and develop those algorithms and protocols together as a multidisciplinary interventional practice, maybe that's the way you need to do it. Or in other cases, you know, in my experience, what I've seen is people can't run the other way fast enough. And so the people who are passionate about it, we focus our energies, we become really good at it. And we reach across the aisle and say, hey, you got a patient? Please, you know, send them to me. Just today, I had a vascular surgeon send me a patient and a cardiologist send me a patient, just today. And I found these patients while I was reading the list in radiology. I mean, can you believe that, right? And but I do believe it because they're so busy that they need someone who's focused on this to really push it forward. And your environment may be different, but I think no matter where you go, we find no shortage of passionate people, no shortage of experts. And you just got to find your way to work in that environment. I'm confident it can be done.
Kapil, what's your thoughts on this?
Yeah, I mean, I completely agree. I think there's no point in every specialty working in a silo. Our patients and everyone would be much better served if we collaborate. There's plenty of disease out there. And if we really work together to find that untapped that need that patients have, I think we can reach a lot more patients and catch clot a lot earlier. And every specialty kind of comes at it with its own perspective, right? So as an interventional radiologist, we were trained in radiology, and so a lot of times a vascular surgeon or a cardiologist might come to me with a case of DVT or suspected May-Thurner's or something, and I might have read the CT venogram for that patient and have something of value from a radiology perspective to provide, and the same holds true for those fields as well. And so I think discussing it as a group the same way we do, and more institutions are converting over to a PERT team kind of setup for PEs. And I think learning from those experiences and experiences from other more acute disease processes like strokes, like STEMIs, I think we can respond to this disease process as well and do so collaboratively and maybe reach even more patients.
Well, I'll tell you, it's clear to see the passion both you bring to the table. And selfishly, I could talk all night, as you both know, unfortunately, on this topic. But I do want to conclude. I want to say, first of all, before we conclude, I'd like to take a moment to sincerely thank our two outstanding guest speakers, Dr. Kapil Wanamore and Dr. Alex Mizzono, for sharing their time, their insights, and expertise with us this evening. I'd also like to thank each and every one of you for joining us virtually for this ACES Learning event. Your engagement and participation are what really make these sessions impactful. So thank you for joining us. Please stay tuned for details on our next ACES virtual event. We're looking forward to welcoming you again soon. And thank you all, and I hope you have a great evening. Once again, thank you, everybody. Thank you, Alex. Thank you, Kapil. Appreciate you so much. Thank you.
Good night.
Thank you.
Good night.